I certainly appreciate you inviting me to join here. Thank you, Ruben, and Anne for a wonderful venue and for a lovely crowd to talk about myeloproliferative neoplasms and myelofibrosis in particular. And it's indeed that I'm specifically focused on MPN over last 15 years or so, and really do not do much of anything else. We do have opportunity to subspecialize at MD Anderson. We have a number of doctors in leukemia department, and this is the area that was neglected for so many years. And in about 2004, we set to develop the program, and I think we did a remarkable thing so far. But this is only the beginning. And so I will actually, in my talk, span a little bit from 2005 to now. I'll use about 5 or 6 slides at the beginning to describe how things changed. You already know that, but just to give a flavor to where I'm getting at the end and how difficult actually is to see a path forward. It was relatively easy at the beginning, but it's getting so complicated these days. Now, I understand that my English is not very good, so if you don't understand me, you have questions, you do not agree with what I'm saying, or you have your own comments, please raise your hands and let's discuss it. This is not a lecture or anything like this. It's just a presentations with the friends. So let's talk about it. And there will be later on question and answer session, but still interrupt me and ask me questions. So I don't mind. This is how it should be done. Okay, so in the morning there was a presentation by Dr. Gottlieb on the molecular findings or genetics of myeloproliferative neoplasms. And it is all about JAK-STAT pathway, right? So we probably know this by now. Everybody knows what this is. This is the blood. This is the cell, right? This is the membrane on the cell. This is the nucleus where the genes are. This is the DNA. This is very all simplified, right? This is how it started. And we learn about this pathway where there is a receptor. These are proteins that go through the membrane. We call them receptors. And there are proteins that we call cytokines that go around the blood. They attach themselves to the receptors, and there is this JAK. That's an enzyme, a protein, that gets activated when the cytokine binds to the receptor. The JAK activates the STAT, and the STAT makes cell do something. So JAK-STAT pathway is one of the signaling pathways inside the cell. And we learned that this pathway is involved in the blood making, it's involved in inflammation and immune function. But it's not very straightforward pathway because there are many family members of these JAK enzymes. These are proteins or enzymes that get activated and activate other proteins. So we call them enzymes, if you like. And there are several of them. And usually that's not only one of the 4 associated with any of these receptors, except in the bone marrow, the JAK2 enzyme is specifically associated with the receptor for the making of the red blood cells and making of the platelets. That's unusual. In the nature, usually things are not simple. Usually they are complicated, and that's why we have, you can see, a family of these enzymes. But in the bone marrow cells, not in the immune function or inflammation, but in the bone marrow cells, when we want to make blood or red blood cells, the JAK2 enzyme is the one that is associated with receptors for cytokines that signal making of red blood cells and platelets. And we learned in 2005 that there is a genetic abnormality in the gene that makes the JAK2, right? The JAK2 V617F. Everybody knows about this, I hope, by now. And we said this is what makes this pathway active all the time because enzyme is wrong. It makes these cells grow without control. And we said JAK2 mutation makes JAK-STAT pathway active and cells grow without control. That's the problem. And by now, from the early morning, I'm sure that you know that that's not true, right? There are many other abnormalities. It is not only the JAK2 mutation that makes this JAK2 enzyme active all the time. There are several other mutations that activate JAK-STAT pathway, right? You know, calreticulin mutation and MIPL mutation, so there are other mutations that activate JAK-STAT pathway. But every single patient has active JAK-STAT pathway. That's the bottom line. And there are many other mutations along the way that were presented in the morning that we are now able to discover, but sometimes we don't even know what they do. So JAK inhibitors were developed because we said, okay, there is a JAK2 mutation, there is a hyperactive JAK-STAT pathway, it makes cells grow all the time. We want to inhibit that. We're going to inhibit that and we're going to kill those cells. Well, we did not succeed in developing JAK2 mutation-specific drugs. It appears to be biochemically impossible, to simplify again. So we don't have a specific JAK2 mutation or calreticulin mutation or any other mutation that you may remember. We don't have those specific inhibitors. What we have is inhibitors of the JAK-STAT pathway. They would calm down the growth of the cells. That would lead to improvement in quality of life, improvement in the spleen size, decrease in white cells, decrease in platelets, but also decreasing the platelets and red blood cells. That is depending on the JAK-STAT pathway, right? That's the side effect of the inhibition of the JAK-STAT pathway in the normal person. You inhibit the JAK, the normal JAK, you decrease the red blood cells and platelets. So JAK inhibitors are not selective. They can cause some suppression of the blood cell count, and therefore elimination of the disease is very unlikely. This is the bottom line of the JAK inhibitors or JAK2 inhibitors. They can inhibit the growth of the cells and decrease inflammation. And we already know they also affect some functions of the immune system, as it was mentioned before, because the JAK-STAT pathway is important in blood making and inflammation and in the immune system. So we have to deal with those inhibitions, if you like, or effects of inhibition. So what does a JAK inhibitor do for a patient with myelofibrosis? Some of you don't have myelofibrosis or have not seen advanced patient with myelofibrosis. This would be a typical patient with advanced myelofibrosis. And this is something that I have taken from my own patient 10 years ago. And many of you have maybe seen these pictures. But picture is always worth 1,000 words, and my words are always complicated. So you can appreciate the problems, right? Organs. This is a spleen here. You can really see the measurements of the spleen. It's a very big spleen. There is enlargement of the liver, and the patient is, we call this cachectic, loss of weight. This patient came to me in a wheelchair, unable to walk. And then with the JAK inhibitors, what do? Inhibit the JAK-STAT pathway. So cells start to grow less. We can't completely shut it down because then there will be no normal production of the normal cells as well. You have to balance between inhibition of the abnormal growth and normal growth because they're not specific for the JAK2 mutation. And this is what happens, right? The organs decrease. They are still present but much smaller, and the patient gains weight, and then patient walks and enjoys life fully, and this can last for years. And when we started this, I always got a critique from my own colleagues in the field that we are not eliminating disease. We are not eliminating disease. We are controlling the signs and symptoms. And then there was a word, palliation. We are just palliating, this like end-of-life care just to make people feel better. But now we know that people can live longer for a few years with the control signs and symptoms of the disease, because you can imagine that this particular situation here is deadly. In a short order, patient is unable to walk, unable to eat, because the symptoms, the spleen and the liver press on the stomach here, right? So continuous weight loss, disability, and untimely death at a slow pace, but untimely death. So in this situation, you continue to live with a good quality of life for many more years. Not forever, no drug works forever, but it can last for many years. So that's one of the benefits of the therapy. Good control signs and symptoms that lead to prolongation of life. even recognized now by the FDA or regulatory bodies as the benefit of the JAK inhibitors. So no complete remission or elimination of the disease, but control. That's the reality of what we can do. Oops. This is now a picture of the, remember the easy picture that I showed, JAK-STAT pathway? Now we jump 10 years later. And anybody see JAK-STAT pathway here? You can't even see it, right? And this is simplified. Okay, this is simplified. This is not actually the what else we found since then. The JAK-STAT pathway is here. This is a cytokine, the JAK, the STAT. So this is outside. That's the blood. This is the cell inside. This is the membrane. And I only showed some receptors. There are many other receptors here that, because of complexity, I didn't want to show. There are others that also are contributing to the disease process. What is down here is the nucleus where the DNA is. And what I'm showing, apart from the JAK-STAT pathway, is everything else that we found not normal in the bad cells, malignant cells that we have in the patients. So as we go through time, we are able to identify many, many other abnormalities that are present in the bad cells in the patients with myelofibrosis. And by the way, this is going to be online for you, and all this is being taped, so you don't need to take pictures or write down, and so it will be there for you to review at a slower pace with perhaps better understanding. So this is just an attempt from one of the review articles recently to try to summarize what's wrong, and it's incomplete, there is more, right? But you see where we got from the one single straightforward JAK-STAT pathway to all of this happening, what's wrong. Now, there are some boxes here. See, these are boxes here, here, and here, and here, and here, and here, and here. These are boxes with funny names. Everolimus, Navitoclax, AU922, and so on. These are medications. These are medications that we are trying to utilize or develop or test, if you like, as therapies for patients with myelofibrosis. Not just to target the JAK-STAT pathway with the JAK inhibitors, but to do something more. And so this group of medications, these three, would be inhibiting this particular enzyme called PI3K. PI3 kinase. These two, Navitoclax and Venetoclax, would be inhibiting BCL2 or BCLXL, and so on. So these are first identifications of what is wrong, and then our attempt to develop medications for those particular problems, in addition to targeting the JAK-STAT pathway, which is the bottom line of everybody's case. Now, why is this important? We talked so far about ET, PV, and myelofibrosis, right? And you have a JAK2 mutation patient with ET who has a normal life expectancy. You have a JAK2 in PV who may have a little bit shorter, but close to normal life expectancy. And you have a JAK2 mutation patient with myelofibrosis who may have only a few years to live. So there is something else that is causing the aggressiveness of the disease. And these are these other things that we have been discovering, because the outcome of the patient, obviously, it's not only dependent on the presence of the JAK2 mutation or one of those driver mutations. It's dependent on the presence of all these other abnormalities. And these other abnormalities lead to more aggressive type of the disease in particular person. So when you have a visit to academic centers, then we do extensive genetic testing, for example, to try to see whether there are many other mutations. We test you also for abnormalities in chromosomes that carry genes. These are finger-like structures in the center of the cells that carry genes. But many times we are not actually able to test you for any of these other ones that I showed out, because these are not really mutations. These are abnormalities in functions of different proteins. These are biological abnormalities that we cannot really explain or test for as of yet. we can target them maybe with certain medications. And these are clinical studies that we always talk about when we see patients. Can we do better than just inhibiting the JAK-STAT pathway? Can we utilize different drugs that would affect other biological abnormalities that we know of in these patients? So far, so good? Any questions? My English is okay? Yes?
What you're talking about, those are still not curative, they're still controlling.
The question is this curative, or these studies are curative with these medications, or just controlling? Well, the goal would be always, or a hope would be always, that we do have a medications that would target particular problem that is so essential for that cell, bad cells, malignant cells, that that cell would die off, and we would be able to eliminate disease. More realistic is that we would be able to minimize the disease and control the signs and symptoms for much longer. So realistically, we are controlling the disease, and the goal, realistic goal, is to make it controllable or under control for much longer, so that people live decades, perhaps, with the controlled disease. The elimination of the disease is very high bar. We only do this this time and age with the transplant. Transplant is the only way to cure patients with myelofibrosis. Good question. Okay. So, from the picture to a list. All right, so how do we choose? What shall we do? What shall we test, right? These are groups. Actually, this is not a list of medications at all. This is just a list of classes of drugs. I told you this PI3K, right? There are at least 3 different studies underway in the United States with 3 different PI3 kinase inhibitors, right? And then look at the list. Most of these sound so complicated, you don't even know what that is. And these are, look, we have Hedgehog here too. That was a trick for you to find it. It's true, it's actually not a joke, but right, and we have some other JAK inhibitors, right? Other JAK inhibitors. 3 more JAK inhibitors. Why do we have JAK inhibitors when we already have 1? We actually tested 11 JAK inhibitors in the clinic to find the best. And it just happens that one got so good from the beginning that got approved, and others didn't match it, or were more toxic, or there were some complications in drug development for other reasons. And we always want more than one. They're not all the same. They may have the same desirable effect, but they are different chemically. They may have different profile in terms of side effects, and we want to develop more than one, or try to treat patients with one after another and see whether this will make sense. So 3 are still in contention: pacritinib, fedratinib, and NS018. Doesn't have a name yet. But I'm going to really talk about all these other ones. So once you discover abnormality in those bad cells, you would say, why don't we utilize one of the medications from one of these classes? And this was obviously an urge to, let's try everything that we can. And this is what happened as an example. This is 2014, not too long ago, right? So we said, we're going to combine ruxolitinib with this particular medication. Okay. Then we're going to combine with this one. Doesn't have a name. It's called LDE. Or we're going to combine ruxolitinib with BKM. Most of these drugs don't have names. They are truly investigational, right? They, in the lab, many times work together, and they would perhaps enhance what the ruxolitinib does. So they are just combined. And how do you judge your response then? You look at the spleen response. This is an example. You don't need to read the numbers. I'm just trying to convey how this work is done. What are we trying to achieve, right? So we add the medication to ruxolitinib. These are 1 study, 2nd study, 3rd study. And then we look at the result and we say, oh, is it better than what ruxolitinib alone would do? And we usually look at the quality of life and the spleen. So these are the spleen responses and mean spleen reduction. But the main message of this slide is this: adverse events. Too many. we learn a lesson many times that rushing and treat patients with the combination from the very beginning may not be the best way to go and may affect the patient's overall outcome. So look, diarrhea 68%, 18% says grade 3 or 4. The toxicities are usually graded between 1 and 4. 1 is very mild, 2, 3, 4. 3 and 4 are too much for the patients to stand, and nobody likes those. So we have here diarrhea, asthenia, fatigue, and many have a grade 3 and 4, which is unacceptable. Here the same, many problems, many problems. We learn a lesson that just because there is the hypothesis that you can test in the mouse or in the laboratory's dish, that does not really translate right away into success in the patient, and you need to do perhaps a little bit more careful approach in selection of the patients or understanding what the medications together would do. So that's the key questions right now. Who are the people, the patients that we should be utilizing investigational agents? Not just because we can, we should do the better way to identify patients, and eligibility criteria these days are much more precise to select patients for particular studies based on the hypothesis what the new medication would be doing in these patients, not just because it's there, right? Any questions? Okay. So this is now ASH 2017, right? So this is the selection of studies. I didn't want to analyze one study by one study. There is no point. The concept is important. So we had studies, you see, we go back to Hedgehog here. Combination with Ruxolitinib. There was another Hedgehog alone. This is a second line, 2Ls meaning second line. That's after Ruxolitinib. Dr. Mascarenhas was talking about the medication that he was testing in ET and PV. You see different classes of different drugs. We are witnessing evolution in understanding of the biology of the disease, and the nice photo that I showed you of all the abnormalities, it is truly incomplete because we are continuously discovering new and new targets for new medications, and we move through time by adding more possible combinations, but we are also much better in identifying the particular patient that would benefit from that particular new intervention. Dr. Mascarenhas was talking about the P53 gene, right, which make a difference whether it's mutated or not for the drug that he was testing, the adesinatline. So genetic complexity or genetic profile or particular clinical characteristic of a patient would be selecting that patient for one of the studies. Not all comers. Whoever is there with the disease, let's test a new drug or new combination, but specific characteristic of that patient would lead to suggestion to participate in one of these clinical studies. Okay, so let's highlight several of the drugs because there are so many, and let's see which are possibly really worth pursuing, because we do many pilot studies. That means, okay, we have a group of patients that would possibly benefit the best. We have a drug that possibly is active and safe. Let's do a pilot study. That means 10 or 20 patients that are in need of help, and let's see whether these drugs works. And we should also look beyond just controlling the spleen and the symptoms. You know very well there are many patients here with myelofibrosis. I know that as a fact, that it is also about the anemia, or also about the low platelets, also about increasing blasts. These are the leukemic cells that people, about 20% of myelofibrosis patients, transform to acute myeloid leukemia. That means the blast, the leukemic cells come from the bone marrow and blood to a levels which is above 20% or more blast, baby cells in blood or bone marrow. It's called acute myeloid leukemia. So it's not only about the spleen and symptoms. It's the spleen, symptoms, low blood cell count, particularly anemia, and transformation to a more aggressive type acute myeloid leukemia. These are the usual factors that would tell us that we need to intervene and treat the patient. So this particular drug, which is called ACE11, has been studied in patients that have myelofibrosis and have anemia. So there will be 3 drugs that I will highlight here for you to see as an example of some excitement that we have in the field about this particular early results. Okay, what is this drug about? I try to simplify this for myself to be able to project that. Okay, we talked in the past that this is the membrane on the surface of the cells, and these are receptors, right, for different proteins. You are by now familiar with that from the very beginning of my talk. So this particular medication, ACE11, is a construct. That's the drug that has a part of the receptor and part of another protein. It's a made-up protein which traps different proteins that would enhance the aggressiveness of the disease. Okay? So this is a normal function on the red blood cells. The proteins that go through the membrane are called receptors, remember? The ligand is the cytokine that binds to the receptor, and then we introduce the medication. That's the medication here that prevents the binding to the membrane of the red blood cells. This is not related to the JAK-STAT pathway. This is unrelated to JAK-STAT pathway again, completely different aspect of the biology of the disease. And so this medication would be allowing red blood cells to mature, and you would resolve the anemia in patients. So this is one of the examples of what happened in real life. This is the time. These are the dates, exactly the dates. It's an example of one of the patients. This is the measurement of a hemoglobin, measurement of the anemia. This is over time. These are the units of blood that the patients were receiving, all these arrows. So 3 units of blood, the hemoglobin goes up, then it goes down. The 3 units of blood, up, down, 3 units of blood, and you follow the pattern. Then there was the introduction of the medication, which is given under the skin every 3 weeks. Each arrow is 1 injection, and no more transfusions. The number stays up. If it's too high, we don't even give injection. And it goes on like this over time. So that's one of the success stories in this particular patient. You say, how many patients are responding? This is where we are. About 40% of the patients respond so far. So it's a good signal, right? It's a pilot study. 35 patients so far. 4 patients that are anemic. They may be on ruxolitinib or may not be on ruxolitinib. It doesn't really matter. It has nothing to do with the JAK-STAT pathway, with ruxolitinib inhibition of JAK-STAT pathway. So it can be combined. It's outpatient injection every 3 weeks, and this is ongoing study. Where are we going from here? The company that stands behind that has a similar drug called ACE536, which is being tested in myelodysplastic syndrome. That's similar to myelofibrosis, not the same, similar disease of the bone marrow. And they already have a phase 3 randomized study for approval underway with ACE536 in this condition. So the company decided, and that's why I'm talking about this today, to do global multi-center phase 2 trial to confirm these pilot study results across the globe with this new drug 536 in myelofibrosis for patients that are anemic, where they may or may not be on ruxolitinib. So this is something to look for, because I don't have a good drug for anemia. I see many of my patients here, they know that anemia is a major problem. We have a JAK inhibitors that can do good for most of the patients for the spleen and symptoms, but they do lower the blood cell count. That's why I was explaining this at the beginning. What do you do about anemia if it's already present from the disease or if it's caused by the therapy? You can't do much. So anemia drug is one of the targets for the new drug development, clinical target, right? So this is the one good lead, and we're going to come back to the clinicaltrials.gov. This is where all the action is posted. Everybody knows about the clinicaltrials.gov? That's the place to go. See, all the studies are listed there, eligibility criteria and places where the studies are done. Okay, let's move on to a study that Dr. Mascarenhas is very familiar with. 20% of the patients transform to acute myeloid leukemia. And I try to summarize what this means. In myelofibrosis, you have a big spleen, you have a loss of weight, a lot of symptoms, anemia, thrombocytopenia, and for some reasons, and maybe because of genetic complications or genetic background, baby cells blast, go up, 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 and up. More and more of them are produced, and they do not mature. There's just accumulation of the baby cells called blasts. When the blasts go above 20%, then we say, wow, you developed acute myeloid leukemia. It's so aggressive that there will be no maturation of these baby cells, and all the red blood cells, white cells, and platelets decrease, and this is very aggressive state. The life is very short. Now, between 0 and 20, there are many points here. So we say accelerated phase is when you have between 10 and 20, and when you have more than 20, then it's called blast phase or AML. So this is for patients. This is a study that is underway. Combination of ruxolitinib, the JAK inhibitors, to control the spleen and symptoms, right? And the medication called decitabine to control the blasts, right? And there are two studies. One is done by Dr. Mascarenhas and his colleagues in the MPN consortium, one other at MD Anderson. And it's becoming more and more standard practice because the results are promising so much for these patients where there is really not much to offer when you are in this phase that it is really, I use it all the time, decitabine or a similar medication called azacitidine. Commercial names are Videsa or Dacogen. Whenever blasts are going up, we try to utilize these medications. They are not approved for myelofibrosis, but they're there to be used. And so this study is underway, and this study at MD Anderson. I'll show you early results. So this is again ruxolitinib and decitabine. 20 patients that develop blastic phase, they have acute myeloid leukemia from myelofibrosis, and it is all about survival at this point in time. So this is the survival of the patients in red color without any response, and the blue line is with a response. Very small study, but it does appear to my eye that, and I use this all the time, that we can actually control the disease, perhaps for a longer time, and perhaps make patients do a bone marrow transplant at one point in time, as soon as possible, actually, to save patients' life, because this is very aggressive state. So beyond the JAK inhibitors that control the symptoms and spleen, we are looking at other clinically relevant endpoints. This is anemia, this is the progression to acute myeloid leukemia, and we are developing new therapies here as well. And there was a question already about the goals of the therapy in myelofibrosis. Realistically, in myelofibrosis, you would like to control the disease. Can we cure a disease? Is there a drug that can do that? Not only talking about acute myeloid leukemia. I can tell you that there is one, but there are preclinical models, mouse models, that would indicate that some of the new drugs perhaps may do that. And one of these is here. This is my last drug that I would like to highlight, and this is called PUH71. All right, what is that, right? PUH71. Now, I didn't highlight this before because it's just going to go away, but this is one of the new inhibitors that it's inhibiting, well, HSP90. It's beyond the explanation. It's not very simple. The JAK2 protein needs to actually be carried around the cell, and this particular HSP90, its chaperone, it carries the protein around, and you are inhibiting this. So it can possibly be combined with the JAK inhibitor, right? And because it will inhibit the JAK2, and so JAK inhibitor inhibits JAK-STAT pathway, this drug would inhibit the JAK2 enzyme as well. Maybe you should combine it. So this is the mouse experiment. You have a % survival from 0 to 100. These are mice, right? Mice with the disease. They die off here. This is the blue line is the therapy with the ruxolitinib, Jakafi. And the black line, you may have not seen the black line. It didn't move. It stayed up here at 100%. This is the new drug. So maybe combination of this is the combination of the ruxolitinib and the new drug together. So the p-values are here. This was experiment that was published, suggesting that these two drugs together might control the disease. I would not say cure, might control the disease in mice that no mice die. That would be much better, right, than anything else. So this study, actually with this HSP90 inhibitor, is being also opened. I don't think that it's open yet. It's going to open anytime in about 10 centers, 12 centers around the United States to combine PUH71, it doesn't have a name, with ruxolitinib. It's going to be given to patients that are on ruxolitinib already in need of help. They need to have something to treat, spleen, symptoms, anemia, and so on. So that appears to be exciting from the laboratory standpoint. Very nice laboratory evidence of the success of a combination. So where do we go again for our information? What studies are there? What is being done and where? clinicaltrials.gov, and this is definitely incomplete list because it's changing all the time. It is really hard to keep up for the federal government. That's the federal government site, to know exactly, is it open today or is it closed tomorrow? There are always situations where the study is on hold, or it's terminated early, or it's expanded, or it's changed. But this is the best site for a summary of ongoing studies. And then MPN Foundation has its own website where we do this every 3 months to update that site as well with much more information in addition to clinicaltrials.gov. But clinicaltrials.gov is the one that people use quite often. So this is selected investigation agents alone, and then combinations. Why are we looking at the combinations? We want to do better than Jakafi alone, but build on it. Utilize it as the backbone for jumping up to other benefits. So my last slide. I did not talk much about the molecular signatures. Molecular complexity affects the outcome of the patients. I indicated this by utilizing using the exam of JAK2 mutation present in a patient with ET who has normal life expectancy, or myelofibrosis that doesn't. So there is genetic complexity or molecular complexity that should be analyzed in the patients, and hopefully soon enough we're going to utilize this in clinical decision making once we have more drugs. And these are the obvious goals from my presentation. Where are we getting and what are we doing and why? And particular emphasis this time and age is for patients that are progressing to acute myeloid leukemia, because this is the deadliest complication you can have. It's not very common, but it's really detrimental for the patients that are progressing. And eventually, and I have a question mark here that's at the bottom of the slide, prevention of progression. Are there medications, and we don't have them yet, that we would be able to give anybody before they have any problems at all? When they don't have a big spleen, or don't have a significant anemia, or don't have a very high blast, because at this time and age we still don't have anything for prevention. We wait usually for problems to develop and then we intervene. We don't have anything right at the moment to say, oh, you have a disease but you're doing well, why don't we give you something so you do well forever, instead of waiting for things to change. This is the sad part, that we still have to realize it's in place. That's where we are. So we have a hope for many new drugs to work, and I hope in next 5 years that we have at least 2 or 3 new drugs that will be available, and that we move on to talking and developing new drugs for prevention, not just for intervention when it's necessary. So I thank you very much.